Welcome to Improving the Management of Patients with DMD, Emerging Evidence and Treatment Strategies. I'm Crystal Proud, Director of Neurology and Neuromuscular Medicine at the Children's Hospital of the King's Daughters in Norfolk, Virginia. I'm joined by my colleague, Erica Finanger, who's a pediatric neurologist at OHSU in Portland, Oregon.
Hello, thank you for having me. My name is Erica Finanger. I'm a pediatric neurologist at Oregon Health and Sciences University Dornbecker Children's Hospital in Portland, Oregon.
Our goals for this activity include being able to describe the role of dystrophin disruption and restoration in the progression and management of Duchenne muscular dystrophy, assess the latest clinical trial results across various treatment modalities for DMD, and we will examine emerging approaches to DMD management that seek to align patient selection, treatment choice, and optimal initiation of therapy.
Thank you, Dr. Proud. I'm going to start today with an introduction on dystrophin, the protein responsible for Duchenne muscular dystrophy. The DMD gene, which is responsible for producing the dystrophin protein, the absence of which results in Duchenne muscular dystrophy, is a large gene located on the X chromosome. In DMD, a range of different mutations can result in abnormal protein, including deletions, duplications, and point mutations, amongst others. In all cases, the reduction in dystrophin leads to damage of the muscle tissue and degradation with time. We see this here on the right in muscle biopsy with healthy muscle on the left and diseased Duchenne muscular dystrophy tissue on the right. So dystrophin in the muscle does serve as a molecular shock absorber as depicted here. We can see that in the normal state, dystrophin is a link between actin, which is depicted on the far left in brown, and the sarcolemmal membrane and the dystrophin-associated glycoprotein complex embedded within the sarcolemmal membrane. And again, with muscle contraction, we see that the dystrophin is allowed to unfold, thus acting as this shock absorber, allowing for integrity of the muscle membrane to be maintained. Dystrophin acts as a molecular shock absorber within the muscle, and we see here depicted on the left, dystrophin in its contracted form, binding with actin on the left-hand side of the screen here, and with the dystrophin-associated glycoprotein complex embedded within the sarcolemmal membrane proximally. As muscle tissue tracks, you see that the dystrophin unfolds, again acting as that shock absorber, allowing for muscle integrity. Lack of dystrophin, on the other hand, leads to progressive segmental necrosis and muscle degeneration, which is the cause of muscle breakdown in Duchenne muscular dystrophy. So here we see with absent dystrophin, we see a mechanically weakened plasma membrane, which undergoes interval focal tears due to contractile activity, and again, loss of that shock absorber function from dystrophin. With this muscle breakdown, we see an influx of extracellular calcium and eventual segmental necrosis and muscle cell death. On the right here, we see that with this segmental necrosis, we see leaking of creatine kinase into the serum, which again is the measure that is frequently significantly elevated in Duchenne muscular dystrophy. As far as therapeutic strategies to try to alleviate this progression within Duchenne, first on the left, we see that the gene mutations, as we've talked about, lead to an absent dystrophin in DMD muscle tissue. This leads to an inflammatory cascade and immune response, again, resulting in this muscle fiber injury we just discussed, muscle fiber degeneration and regeneration, and eventually, as this process exhausts itself, to replacement by fat and connective tissue within the muscle. On the right-hand side of the screen, we can see that there are a number of different therapeutic strategies which have been investigated and in some cases approved for the treatment of Duchenne muscular dystrophy. Listed on the top are strategies directed at replacing or correcting the dystrophin genes, so stop codon read-through therapies, exon skipping therapies, and gene transfer therapies are directed primarily at addressing the dystrophin mutations. Next, if we're addressing the inflammatory aspect of the disease, corticosteroids and sometimes NF-kappa B directed agents or HDAC inhibition, both of which will be discussed a bit later in the lecture. And then later, there are approaches looking at anti-fibrosis, trying to intervene later in this cascade of events for Duchenne. And noted to the right, we are now that we have some basic therapies available, starting to consider should combination therapies be instituted. So again, this is a summary of the available therapeutic classes for Duchenne muscular dystrophy. Again, sort of reiterating what we've said previously, gene transfer therapy, which will be reviewed, exon skipping therapy, glucocorticoids, small molecule therapy, and cell-based therapies. Before we talk about the therapeutic approach, it's important to understand and review briefly the progression of untreated Duchenne muscular dystrophy. You can see here the progression from birth until the 20s depicted here. Within the first 3 years of life, there are signs of muscle involvement with delayed motor milestones, which can be detected if looked for very carefully. Typically, though, patients do not come to clinical attention and diagnosis until closer to age 5, at which time there is prominent muscle weakness. Usually parents are noting things like difficulty getting up from the floor, difficulty running, keeping up with their friends, and frequent falls. From this point, we see continued deterioration of muscle function and unfortunately loss of ambulation, typically between age 10 and 12, again in untreated boys. By the teens to 20s, we are starting to have respiratory and cardiac muscle involvement with, by 15, many patients requiring non-invasive ventilation support at 9, and by the 20s, suffering significant cardiopulmonary complications and mortality in the 20s. So if that's the untreated progression of Duchenne muscular dystrophy, as we try to institute therapies, it's important to measure objectively some of these motor functions so that we can follow them throughout clinical trials. And here we're going to discuss 3 timed function tests, which are classically used in clinical trials. The first is time to rise from the floor and is depicted here. I will mention that these tests are performed by trained physiotherapists who are retrained every year and have a very standardized approach to doing this. And so certainly when it's done as part of a clinical trial and in most neuromuscular clinics, this is done in a very standardized fashion so that the times can be replicated. So time to rise from the floor is exactly as it is described. The 10-meter walk run is similar. We just time the time it takes for a boy to run or walk for 10 meters. And then finally, the 4-stair climb. Again, this is a standardized rise step for which they are timed climbing 4 steps. Next, we have the North Star Ambulatory Assessment, and you'll see that this measure is used in the vast majority of Duchenne muscular dystrophy trials. This is a 17-item checklist, which does combine 2 of the items from the previous slide, the time to rise and the 10-meter walk run, but also has 15 other items, which are all scored as a 0, unable to perform, 1, performed with difficulty, and 2, able to perform. You can see depicted in the graph on the left that there is quite a bit of variability in the progression of these scores, but you see that over the first few years of life, there is increase in the score with a peak typically attained at 6 years of age, 6.3 years of age, specifically here at a peak score of 26 points. And thereafter, on average, boys decline in this functional measure by approximately 4 points per year. Next, if we talk about considerations for goals, we have different goals and different things that we follow as patients move through the progression of their disease. And you see here the phases of disease described as the ambulatory phase, early non-ambulatory phase, and late non-ambulatory phase. In the ambulatory phase, as you can imagine, our primary goal is to prevent or prolong the time before loss of ambulation. So really focusing on gross motor function and walking and maintenance of standing as well. We are also considering both respiratory and cardiac at this time and trying to prolong the need for ND intervention, although this is unlikely and unusual in the very early ambulatory phase. In the early non-ambulatory phase, boys have obviously lost the ability to ambulate, and we are changing our focus primarily to looking at preserving upper arm function. Here, it becomes important to continue to focus on trying to optimize respiratory function so as to prolong the need for nocturnal non-invasive ventilation or assisted cough. And again, focusing on cardiac to prevent cardiac decline and fibrosis. The late non-ambulatory phase, our focus primarily is on hand function, which is typically preserved longer in the course of disease and allows for independence, such as controlling motorized wheelchair or computers and individual devices. At this phase, we are, again, trying to provide optimal support for respiratory, but we need to be considering diurnal non-invasive ventilation, and again, focusing on trying to preserve cardiac function as best as possible.
Let's review a case. This is Sammy, age 4. He's the younger of 2 boys diagnosed with Duchenne muscular dystrophy. His older brother, Lucas, age 9, was diagnosed with Duchenne at the age of 4 after genetic testing showed a deletion of Exon 52. Recognizing similar difficulties in Sammy, their parents took him to the clinic, where he received an official diagnosis of DMD. Currently, Lucas undergoes a treatment regimen combining exon skipping therapy and corticosteroids. Although satisfied with Lucas's care and management, the parents are aware that he may lose his ability to walk and are exploring other options for Sammy. Sammy is treatment naive. Let's discuss genetic-based therapies for Duchenne muscular dystrophy. Here we see the strategy for delivery of a miniaturized but functional dystrophin via gene transfer therapy. The typical dystrophin gene encodes for a protein that contains 24 repetitive sections and 4 hinge regions. Unfortunately, the entirety of the dystrophin gene cannot fit into a viral vector for gene delivery, and thus components of the DMD gene are selected in order to create a miniaturized but functional transgene. An adeno-associated viral vector can then shuttle this shortened micro or mini dystrophin into the nucleus of muscle cells, which should then produce microdystrophin. Here we see a schematic of how gene transfer takes place. The gene therapy consists of viral capsids, in this case containing a dystrophin transgene, and this is injected intravenously into the patient. Most commonly, an adeno-associated viral vector is used. This vector allows for administration intravenously, whereby then the vector is transferred into and through the muscle cell membrane, makes its way into the nucleus of the muscle cell, where the transgene is then released. This single strand of DNA then can form a second strand, complementary, and then zip up to create an episome, which subsequently allows for continual production of the protein, in this case, dystrophin protein. Numerous gene transfer therapies are in clinical trials for the treatment of patients with Duchenne muscular dystrophy. Delandistrogene moxeparvovec was the first FDA-approved gene transfer therapy for DMD, and this received its approval in 2023. Ortodistrogene movaparvovec and the Genethon 0004 studies are in phase 3 clinical trials. RGX-202 and SGT-003 are also in phase 2 clinical trial programs. There are various clinical considerations for gene transfer therapy that must be taken into account prior to infusion, on the day of gene transfer therapy, and following the infusion. When we are selecting a patient for potential candidacy for gene transfer therapy, it's important for us to screen that individual for the potential presence of antibodies that might preclude them from receiving the specific treatment. We also need to avoid co-administering them with vaccinations, either pre-infusion and for a period of time after infusion. Vaccinations should be avoided. In addition, gene transfer therapy should not be administered to a patient who has an acute illness, and so we would consider postponing dosing. Prior to infusion, we can see that labs are required, including liver function assessments, cardiac assessments such as a baseline troponin I, baseline platelet count, and we also will pursue administration of a corticosteroid prior to treatment and then for a period of time after the infusion. Following the infusion of gene transfer therapy, we will continue to monitor labs, including blood counts and liver function assessments for specified periods of time, including up to 3 months. These laboratory monitoring parameters may be extended if we see adverse effects. In addition, the corticosteroid is continued following infusion in order to mitigate adverse effects, including the potential for hepatotoxicity. This may need to be adjusted if hepatotoxicity is identified. Delandistrogene moxeparvovec was approved in 2023 as the first gene transfer therapy for the treatment of patients with muscular dystrophy of the Duchenne type. This was FDA approved for pediatric patients ages 4 and 5 years old with a confirmed mutation in the DMD gene. This approval was based off of efficacy and safety results from 3 clinical trials. The first clinical trial was performed in Study 101 with 4 boys who received the gene transfer therapy and demonstrated efficacy. They are continuing to be monitored and have demonstrated maintenance of their improvements in their North Star Ambulatory Assessment scores for at least 4+ years following infusion. In Study 102, delandistrogene moxeparvovec was evaluated in a double-blind placebo crossover trial. This evaluated boys ages 4 to 7 years old with Duchenne muscular dystrophy. There was a statistically significant difference, particularly in the 4 to 5-year-old age group, whereby the least square mean change from baseline to week 48 showed a significant difference of 2.5 points on that North Star score. Unfortunately, in the older age group, the 6 to 7-year-old group, these were not well matched at baseline, and there was a statistically significant difference at baseline in the North Star Ambulatory Assessment scores of the group that received the placebo and the group that received active product. And thus, they were not able to be effectively compared at week 48. And so there was not a statistically significant difference at that time point. Study 103 has incorporated the broadest cohorts to receive delandistrogene moxeparvovec and is ongoing. In addition, the EMBARK study, or Study 301, is an ongoing phase 3 multinational, double-blind randomized placebo-controlled study evaluating the safety and efficacy of delandistrogene moxeparvovec compared to placebo in boys with Duchenne ages 4 to 7 years old. So these boys were randomized to receive either the IV infusion of active product, delandistrogene moxeparvovec, or a single IV infusion of placebo at the beginning. They were then followed for 52 weeks and would receive the opposite. So if they had received active product, in the second part of the study, they will receive the placebo infusion. And if they received the placebo in part 1, then they will receive active drug in part 2. Outcome measures include items such as the North Star Ambulatory Assessment score, microdystrophin protein expression, as well as other functional assessments. Results from part 1 have been shared, and we can see those here. The North Star Ambulatory Assessment score did not show a statistically significant difference at that time point at week 52. However, some key secondary endpoints showed statistically significant differences. This included the time to rise and the 10-meter walk run, as well as the stride velocity 95th centile. Patients who received delandistrogene moxeparvovec statistically did better than those that received the placebo in part 1. And all of the results that were assessed regarding motor function favor treatment with delandistrogene moxeparvovec. It's important to consider adverse events when utilizing any therapy. And so safety was assessed in 85 patients across 3 ongoing clinical studies, including the 2 open label studies, Study 101 and Study 103, as well as the double-blind placebo-controlled study that we reviewed, Study 102. The most common adverse event includes vomiting. We can also see side effects such as decreased appetite, nausea, elevated GGT, and some others that are listed here. There were some rare cases of entities such as myocarditis and immune-mediated myositis. Another gene transfer therapy utilized for the treatment of Duchenne muscular dystrophy that is currently in investigation is fortodistrogene movaparvovec. This has been evaluated in a phase 1b clinical trial. In addition, it is being evaluated in a phase 3 clinical trial called CIFRIO. In the phase 1b clinical trial, boys ages 6 to 12 years old were permitted, and they were stratified by age, including 6 to 7-year-old boys, as well as 8 to 12-year-old boys. They underwent screening and a baseline muscle biopsy, subsequently received a single IV infusion of fortodistrogene movaparvovec at high dose, and then were followed long-term. This included 16 patients. We can see here the mean change in North Star Ambulatory Assessment score at 2 years by age group in each of these cohorts. In the blue bar, we see that patients treated with fortodistrogene in the 6 to 7-year-old age group had a difference when compared to an external control cohort in the CTAP model of an improvement of 2.5 points in their NSAA score. In the 8 to 12-year-old age group, which would be expected to have declines in the natural history, we see that if we compare the fortodistrogene treated patients with the external control comparator, the CTAP model, there is a difference of 2.3 points as well. 3 treatment-related serious adverse events occurred, including dehydration, acute kidney injury, and thrombocytopenia in this particular clinical trial program. As I mentioned, the phase 3 CIFRIO trial is ongoing, and we look forward to more results in the future. RGX-202 is another gene transfer therapy being investigated for the treatment of Duchenne muscular dystrophy. This is being explored in the phase 1/2 Affinity Duchenne study. 5 boys ages 4 to 11 years old have received a single dose of RGX-202. They're being followed for outcome measures, including safety and microdystrophin expression. We can see that based on the chart here, the first 3 patients, age at dosing, weight at dosing, and the Western blot results showing the microdystrophin percentage. These range between 11% and 83% of microdystrophin production after receiving this treatment. In addition, we can see that there were some significant decreases in CK levels, which are an indicator of muscle turnover. To the right side of the screen, we can see the microdystrophin expression at 12 weeks compared to baseline for one of the patients that received RGX-202. It has been well tolerated in these 5 participants up to 3 weeks to 9 months post-administration. Let's discuss a case. This is Sammy, who is age 6. After discussing with Sammy's parents, it was mutually agreed to proceed with gene therapy for Sammy instead of enrolling him in a clinical trial. After gene transfer therapy, Sammy, now age 6, improved in his ability to rise from a seated position on the floor, and his walking was much faster. However, he still fatigues after a long day of activity and still has some difficulty going up and down stairs. His parents would like to optimize his long-term outcomes, and so they asked the neuromuscular team what other interventions might be beneficial.
So next, as we consider alternative therapies, I'm going to review both exon skipping therapies as well as small molecule and cell-based therapies moving forwards. First, beginning with exon skipping therapies. So before we discuss the specific exon skipping medications available, I just want to review the mechanism of action, in this case using exon 51 as an example of the mechanism. So in normal dystrophin, again, all of the exons are present, and when the ribosome translates the mRNA into protein, we get a full-length normal dystrophin protein. If, on the other case, we have a deletion within the gene, which results in an out-of-frame mRNA, the ribosome is interrupted, and the result is an unstable dystrophin protein, which is degraded by the body. In exon skipping therapy, we use a PMO to change the reading frame, excluding an additional exon, in this case, exon 51, such that when the ribosome translates the mRNA into protein, we get a shortened but partially functional dystrophin protein. So for exon skipping therapies, there are a total of 4 approved therapies and then a number of additional therapies as depicted here towards the right-hand side of the screen that are in current investigations. So you can see the first therapy was approved in 2016, was eteplirsen. Later, 2 therapies for exon 53 were approved and 1 for exon 45. These therapies, again, are targeted to a subset of the population of boys with Duchenne muscular dystrophy, but taken together can potentially treat a fairly large number of boys with Duchenne. For example, the currently approved 4 therapies are amenable to approximately 30% of boys with Duchenne muscular dystrophy. We'll just briefly review each of the approved therapies here, the first of which was eteplirsen, which again is an exon 51 skipping agent. Depicted here is a phase 3 trial comparing boys treated with eteplirsen to an untreated control group of patients with non-exon 51 amenable mutations. And then also in the graph below, you'll see that it was compared to an external control of 2 natural history studies. What we see here is that with eteplirsen treatment, the decline was clinically notably attenuated on the 6-minute walk test over 96 weeks of therapy. We didn't discuss the 6-minute walk test earlier, but as described, this is an earlier outcome measure used in Duchenne muscular dystrophy trials. So golodirsen is an exon 53 skipping agent, which has been studied again in boys with Duchenne muscular dystrophy. Here we see a 12-week double-blind trial followed by a prolonged open-label trial up to 3 years. And as depicted in the 2 images on the bottom, we see that at 3 years in the first and in 6 years in the second, patients treated with golodirsen in the purple dashed line had a slower decline, here measured by loss of ambulation. At the 6-year time point, we can see that golodirsen treatment demonstrated favorable, consistent safety profile and long-term efficacy compared with external controls, here prolonging ambulation by 2.4 years. Viltolarsen is the other approved exon 53 skipping agent. Again, this was studied in a 24-week double-blind placebo-controlled trial with an ongoing open-label extension. Again, we see here the outcome measure is the time to stand and the time to walk or run, 10 meters. And again, we see the group treated with viltolarsen here in blue had a fairly stable course over the 109-week duration. Just to orient you here, improvement is lower on the slide. So what we're seeing here is decline within the natural history group depicted in orange and stabilization of these measures in the boys treated with viltolarsen in blue. The final exon skipping drug is casimersen. This is for exon 45 skipping. This was studied in a phase 3 double-blind placebo-controlled trial over a 96-week duration. These results have been presented recently at the World Muscle Conference. And here we are showing that there is proven exon skipping on the left-hand side with baseline compared with 48 weeks. And also dystrophin production within the muscle, again, comparing baseline to 48 weeks of casimersen therapy. And the final agent is casimersen. This is an exon 45 skipping agent. This was studied in a phase 3 placebo-controlled randomized trial over 96 weeks. The data is depicted here. And what we see is that casimersen significantly increased exon skipping, depicted on the left with baseline values on the far left and 48-week data in the middle there. And it also improved dystrophin expression, likewise at 48 weeks, depicted there in the second graph comparing baseline to 48 weeks. Finally, just to mention an ongoing phase 4 trial enrolling patients treated with eteplirsen, golodirsen, and casimersen in a real-world setting, trying to collect data on patients treated with these therapies in routine clinical practice. On the right, we can see similar open label data showing that patients treated with eteplirsen showed a prolongation of loss of ambulation as compared with natural history. So then if we look at exon skipping therapies from a safety standpoint, here we see all 4 agents listed. We see that there are adverse events, of course, recorded in all patients treated with these therapies. I should mention they are all given IV once weekly. We do see, however, that most of these are adverse events, which are quite common occurring in pediatric patients. And it has been my personal experience that these are very well tolerated agents. So as you may all know, glucocorticoids have been the standard of care for Duchenne muscular dystrophy for decades. Here we discuss 3 particular corticosteroids. Prednisone is listed on the bottom. This is not specifically FDA approved for the treatment of DMD, but has been used extensively. We also will review deflazacort, which was formally approved in the United States by the FDA in 2017, but has been used in other countries and approved there. It is approved for the treatment of Duchenne in patients 2 years and older. And quite recently, the approval of vamorolone for, again, patients 2 years and older. First, to review the data for deflazacort. Deflazacort was studied in 2 different doses as compared to placebo. And on the left, you can see 0.9 per kilogram deflazacort, which is the recommended dose, significantly improved strength compared to placebo at 12 weeks, which is depicted on the left, compared to placebo, which is the white bar. And this was preserved at 52 weeks as depicted on the right graph. Next, reviewing vamorolone, which again is the most recently approved corticosteroid for DMD. Here again, comparing placebo, which is in the darkest blue line, to vamorolone at 2 different doses, noting that the light blue is the 6 milligram per kilogram approved dose. We see that vamorolone improved standing speed, which is depicted on the left-hand side, and 6-minute walk test as well at 24 weeks. Compared with placebo. Regarding adverse events for corticosteroids, we've not included prednisone here because it has not been studied in this way in Duchenne muscular dystrophy, but those recorded in the deflazacort and vamorolone trials are listed here. Again, side effects are well known and quite common with corticosteroids. And we do our best to manage these, but recognize that this remains a cornerstone of therapy for Duchenne muscular dystrophy. Finally, I'm going to review small molecule therapies here and cell-based therapies as the final approach for the treatment of Duchenne muscular dystrophy. Small molecules, briefly here, EDG 5506, which we will talk about first, and then givinostat, which was recently approved for Duchenne muscular dystrophy. EDG 5506 is a selective type 2 fast skeletal muscle myosin inhibitor. In muscular dystrophy, type 2 muscle fibers are particularly susceptible to muscle injury, as we discussed previously, and this therapy is aimed at decreasing the contraction-induced injury present in Duchenne muscular dystrophy. This agent is currently in a phase 3 trial in Duchenne muscular dystrophy with ongoing recruitment and results expected perhaps later in 2024. Givinostat is a newly approved agent for the treatment of Duchenne muscular dystrophy. It is an HDAC or histone deacetylase inhibitor. The exact mechanism in Duchenne muscular dystrophy is yet unknown. However, in the phase 3 trial, as we can see depicted in the figure on the right, patients treated with givinostat showed significant functional improvement at 72 weeks compared to baseline relative to the placebo group. And it may be too small to read, but if you are wondering, each of those lines is one of the functional measures that we spoke about previously. For example, The 4-step climb was the primary outcome measure in this study, and that is depicted on the top, but NSAA and several other time tests are listed further down. Finally, we will review cell-based therapy. CAP 1002 is a trial in Duchenne muscular dystrophy using allogenic cardiosphere-derived cells to treat older boys with Duchenne muscular dystrophy. This particular trial is enrolling boys over the age of 10, whom are both ambulatory and non-ambulatory. Again, the mechanism here is somewhat unclear, but is thought to act through exosomes within these CDC cells. From the phase 3 data here, I'm presenting outcome measure of the PUL, which we did not previously discuss. This is the performance of upper limb. So again, these are older boys, some of whom are in the non-ambulatory phase. And so we are using a outcome measure consistent with that. And in this case, the performance of upper limb 2.0. And what we see here in the blue, which are the treated children with CAP 1002, compared to the placebo group, there is less decline in this outcome measure in those treated compared with those untreated.
This chart demonstrates the currently FDA-approved therapies and therapeutic approaches for Duchenne muscular dystrophy. Glucocorticoids have been the standard of care for many years. They are applicable to all patients with Duchenne, regardless of their mutation. They've been demonstrated adequately to prolong time to loss of ambulation, and they've also demonstrated efficacy with reducing requirements for scoliosis surgeries, and they've improved overall cardiopulmonary function for our patients as well. Unfortunately, these are not without their adverse effects. They contribute to weight gain, changes in mood, reduced bone health with osteoporosis. They suppress puberty and place our patients at risk for adrenal insufficiency. They can also contribute to risk for cataracts and require daily or intermittent but routine dosing. The exon skipping category is another approach that is FDA approved for the treatment of DMD. These have also been demonstrated to prolong time to loss of ambulation and improve pulmonary function compared to natural history. However, they do require frequent dosing intravenously, and many of our patients require a vascular port placement in order to receive these therapies. In addition, they are genetically specific, and they're only applicable to a subset of our patients. They also require monitoring of renal function and have low dystrophin protein production on biopsy assessments. Gene transfer therapy is our next category of FDA-approved therapies, and one that currently is in investigational trials as well. There are minimal genetic restrictions, and so the majority of our patients with Duchenne muscular dystrophy will find that this therapy may be applicable to them from a mutation perspective. There is significant microdystrophin protein production, as demonstrated by Western blot on biopsy results. We have seen improved functional outcomes with administration of gene transfer therapies, and it is a single administration. There is the risk for adverse events, including hepatotoxicity, myocarditis, immune-mediated myositis, nausea, vomiting, thrombocytopenia, and complement activation. And so it must be administered at centers where there is expertise with pursuing treatment with gene transfer therapies. And a subset of patients will be excluded from treatment with gene transfer therapy due to their antibody positivity for the vector. If they are positive for the vector delivery system, at this point, they will not be eligible to receive the therapy, although this is an area of growing research. Combining different therapies for DMD holds the potential to improve patient outcomes and reduce the overall disease burden by targeting multiple different pathways associated with disease pathogenesis. And we remain very optimistic for the future of our boys with Duchenne muscular dystrophy. So in summary, there are several approved therapies for DMD, including glucocorticoids, exon skipping therapies, small molecules, and gene transfer therapies. There are many therapeutics in the pipeline for DMD, including small molecules, cell-based treatments, more exon skipping interventions, and gene transfer therapies. And it's important to align patients, their histories, and their specific goals to the right treatment. This treatment landscape is constantly evolving, and we must evolve with it. In addition, each therapy is associated with benefits and risks that need to be discussed with the patients and their families. Future research will investigate the impact of the potential for combination therapies to impact our patients with DMD, and preclinical and clinical studies are currently in progress.